Talking about VA claims for radiculopathy and VA claims for peripheral neuropathy. Radiculopathy goes up to 90 and peripheral neuropathy goes up to 80. If you have a lower back condition and you have a low ball rating, 0%, 10%, 20% maybe, uh, getting up to 80%, 90%, this could really move the needle for your claim. And then if you've also added in a mental health claim, and you're already at 80% and you're trying to figure out how to get up higher because you're still not compensated properly, I would definitely look at both of these two claims and see if they make sense for you. Let's start with the difference between radiculopathy and peripheral neuropathy. Obviously, I'm not a doctor. I do suffer from both of these. So the easiest way that I can explain this to you guys is radiculopathy stems from the spine itself. And then peripheral neuropathy stems from somewhere between the spine and the body part that's affected. So in my case, I have a herniated disc at L5S1. So that is causing my radiculopathy that shoots down my left leg. Now, I also have numbness and tingling in my right hand. And they did a EMG test to isolate it and find out what part of my nerve was dead. So that test was conducted. It was actually conducted up on my shoulder and over my elbow. So it was away from my spine. So that's the easiest way that I can explain the difference between the two. The most common way that you're going to end up with radiculopathy is actual damage to the spine itself. You jumped, you fell, you got in a car accident, whatever, you damaged your spine, you have a bulging disc, herniated disc, something of that nature, and then that causes radiculopathy shooting into your lower or upper extremities. And then you go have surgery for it, where they cut you open, and then maybe they cut a nerve or a nerve running somewhere else, and you heal up like I did, but you end up with peripheral neuropathy a year afterwards. So that's kind of the difference between the two. Radiculopathy starts at the spine, and peripheral neuropathy is when you're dealing with the limb or somewhere between the spine and the affected body part, which in my case was my hand. Had neck surgery. While they're in there slicing around in there, some other nerve got goofed up and peripheral neuropathy happened as a result. The important thing to remember about both of these valuable VA claims is you want to have them properly diagnosed, and then you want to be able to have your symptoms recorded properly. So when you go to your C&P exam, don't leave any little details out that you've been dealing with and you may think that are small, because I'll share a story with you, and that's what got a veteran 20% in both of his legs. Objective medical evidence is the strongest when we're dealing with radiculopathy. You're going to want an MRI. When we're dealing with peripheral neuropathy, an EMG test, a nerve conduction study test, is the best evidence for that. MRI, you go into the tube, they might give you a Valium or something like that, and you lay in there and it's loud and they might have some tunes and you lay in there for 20 minutes and they do imaging on you. In the EMG test, you go in there, and in my case, I was checking my hand, so they were hooking up electrodes and sending shocks through and finding out, isolating the dead nerve or damaged nerve or whatever. So those are both excellent sources of objective medical evidence, and you want to get that prior to filing your VA claim. As an MRI and an EMG test or a nerve conduction study test are the best types of objective medical evidence that you can get your hands on. As I sit here in March 2021, you might not be able to. EMG tests aren't cheap. They don't just break them off and hand them out like lollipops, and MRIs, pretty much the same thing, though they're a little easier to get. So I said I'd share a story with you. So a veteran went in for an increase on his back. While he was in his C&P exam, he was aware of what was going on, was there to tell his story and talk about his back. So when the doctor had him up on the table, they usually have you lay down, or if they're checking your feet, or sitting on the doctor table or whatever. So he was sitting down and he told the doctor, hey, when I sit down, my legs go numb. So the doctor's like, whoa, that sucks. That's interesting. So he brought out the little rubber mallet tool, the reflex hammer, I think they call it. And he started tapping on his left knee, and it didn't move at all. Like he's just smashing it, and no reflex. And then he goes over to his right knee, and the same thing happened. So this was kind of unexpected objective medical evidence, but the C&P examiner was able to make the call right there. Like, this guy's legs are dead. I think I smashed the reflex hammer into them, and they weren't moving at all. So that's another one of these kinds of things. Doctors, if you give them the right information, they have the tools to do an adequate checkup on you if they want to at a C&P exam. So as a result, the doctor wrote up the report, filled out the DBQ, sent it over to the VA rater. Not only did he get an increase for his back, but he got an extra 20% for his left leg and another 20% for his right leg. So that turned out being a pretty valuable VA claim, and he ultimately got 100% permanent and total in that exam. So that's awesome. Be honest in your exams. Don't hold back. Tell them everything that's going on. To you, you may have been dealing with this numbness every time you sit down for 20 years, and you just deal with it because you have nobody to complain to. You want to make sure and get all these little teeny details out that may seem small to you. To a doctor, they may be red flags like, hey, I better go check them out for radiculopathy or peripheral neuropathy. Most likely, like at a C&P exam, they're not going to be able to like order up an MRI on the spot or a nerve conduction study test on the spot. But they might, order it for some time in the future, or they just may take out the reflex hammer and do it that way. Let's cover VA ratings for radiculopathy. So it comes down to the severity, so mild, moderate, or severe. And then it also comes down to paralysis, neuralgia, or neuritis. Paralysis means if you're paralyzed. So if you have that, you're in one category. That's obviously the highest category. And then you'll have what's called incomplete. So they mean incomplete paralysis. And then it's neuralgia or neuritis, and it's mild, moderate, or severe. Since radiculopathy comes from the spine, you're either going to have cervical radiculopathy, thoracic, middle of the back radiculopathy, or lumbar radiculopathy. So those are typically the three categories that you're going to run into there. Myself, I suffer from lumbar radiculopathy. I have a 10 millimeter herniated disc at the L5S1 joint, the bottom joint in your back. And it's a 10 millimeter herniated disc. I know that because I have an MRI, good, solid, objective medical evidence, right? So they're able to see the herniation. And then I manage that by getting caudal epidural shots once or twice a year to make the radiculopathy more manageable. So that's kind of what my program is, and that's what I'm working on with my pain management specialist. I already had neck surgery. It was a failed neck surgery. So I'm not a big fan of getting your back cut open because there's no guarantees with any kind of back surgery, cervical, thoracic, or lumbar. So I understand this one really well. And I understand how to talk about it because I have the MRI, I have the pain, I got the shots, I manage it, and I'm trying to figure out how to integrate it into my life because, it's not magically going to go away, although that would be nice. No two veterans are alike, no two claims are alike, but the most common fair evaluation for radiculopathy that I see is 20% in each leg. I'm going to put a link to a BVA decision where somebody had a back condition, and then he got a diagnosis and a 0% rating for radiculopathy in each leg, and what his argument was to get from 0 to 20. So I'll include a link to that decision below. And this BVA decision is a good thing for you to look at. I encourage you to look through there. Look at the verbiage they used, the symptoms, because what you're going to want to do to figure out if you have symptoms of radiculopathy, some kind of numbness or tingling or severe pain or something like that, if you don't have a diagnosis yet, it's good to kind of, search around for some words. Do you have any of these words on active duty service? Are you already service connected for your back and now you're experiencing radiculopathy? Do some research as you're working on trying to get an MRI for this thing. It's not the end of the world if you don't get it, because the CNP examiner can still give it to you, but you want to show up strong with as much medical evidence as possible, and that starts with you understanding your radiculopathy and trying to figure out, is it radiculopathy or peripheral neuropathy? That's a good thing to try to establish for yourself. And then how am I going to make this a claim? If you're already service connected for your lower back, it's most likely going to be a secondary claim. So left and right leg radiculopathy secondary to your already service connected lower back condition. Let's talk about VA peripheral neuropathy ratings. The highest rating is 80%, but that is paralysis. So most veterans fall into the severe, moderate, severe, moderate, or mild categories, and that's 60, 40, 20%, and 10%. Peripheral neuropathy is different than radiculopathy because it does not stem from the spine itself. And like I said, the easiest way to explain it is if you had surgery, something like that, or a break or a tear or something like that, something else that's in between your spine and the affected body part. The best evidence that I think you could get for peripheral neuropathy is a nerve conduction study test, the EMG test. There's probably some other acronym names for it. Google them and look them up. I had what was called a nerve conduction study test or an EMG test, so I'm familiar with it. I have a numbness in my right finger in the pinky, and then it's half of this one. So the ulnar nerve is affected. So they hooked up electrodes on my fingers and different parts of my hand, and then they went over the elbow because the ulnar nerve has some issues with the elbow, from my understanding. And then I don't know where they went back, but they did connect it all the way to my spine, and they're trying to figure out, how my neck surgery caused all this stuff. I also have some carpal tunnel as well. So my whole hand's kind of jacked up, and eventually I'm going to have to get that dealt with. In my case, I don't actually have pain. That's one of the things. So I would probably end up it's not service connected. It happened after service. It's not service related at all. I would probably have a 10 or a 20% rating because I have the numbness and I have the tingling, but I don't have the pain. So you don't necessarily need to have the pain, but you need to have the numbness. So be aware of what's going on when people are like, well, what's it like? Well, I type and I grab shit with my hand and I just have like this dead hand. That's a good start, but be prepared to talk about the numbness, the tingling, and how it limits you. That's really what all VA claims come down to, and peripheral neuropathy is no exception to that rule. If I were to attend a CNP exam for peripheral neuropathy, obviously I would have found something to service connect it to on a secondary basis. And then for the medical evidence, I would submit the EMG test, best medical evidence you can submit with this. And then in my CNP exam, I would tell him exactly what's going on. Just like I said, the numbness, the tingling, kind of like a dead fingers, but not the whole finger, just half of it. And, just this is what my life's like. I'll grab stuff and it feels weird. Don't have pain. You don't want to make things up. Don't lie ever, especially at a CNP exam and to the VA, but don't lie, right? And just sit there and like, yeah, doc, it's kind of weird. You don't know what kind of reflex tool or what kind of tool they're going to be using to, check this. And if you're able to go in there and just talk about your symptoms, You could very well walk out with a good diagnosis and then that's going to obviously go to a VA rater, and then you have all the medical evidence. C&P examiner agrees, and VA raters like, yes, claim approved for peripheral neuropathy. All right, I have a little chart here. I want to kind of show you the difference in the form of a graphic. My understanding of the differences between radiculopathy and peripheral neuropathy. So let's go into a screen share. This is a dermatome graphic. I would suggest Googling it and taking a look at it. I'm going to scroll around in here. I'm just going to talk about chasing my stuff around. So I have problems with my digits. So that's over. Let me click on this over here. C8. So if you see this pink band going up here, it's connected to C8, right? I had fusion on C3-4 and C4-5. So something, when they sliced me open, or something happened here, and it's affecting C8 because it's only affecting these two hands. So I'm not sure exactly, how this works. I'm still trying to understand all this kind of stuff. Because before I get any kind of surgery, I guess carpal tunnel / ulnar nerve surgery isn't really that gnarly. But it's still surgery. And then when we go over to my other issue here, I get a radiculopathy over here. Or sorry, I get radiculopathy down the back of my leg here. So there's the L5S1 joint, and you see the yellow band comes down and then it wraps around into your plantar fascia tissue. Also, by the way, this is exactly how you could have plantar fasciitis issues or feet problems, because your back affects your knee, and this is how it's connected. And then S1 is this pink band here, and that also runs down. So somewhere around here is shooting down and causing radiculopathy down through my butt, through my thigh, and into my calf. In my case, it doesn't go all the way down into my ankle. It stops in my calf, so it doesn't go into the ankle or into the foot. It may for you. Dermatome Graphic. It's a good way to kind of sit here and, look at the results of your MRI, look at the medical words in there, look at graphics, however you need to understand this stuff. That's what you should do. And we'll leave it here. I'll see you in the next video.